அனைத்து மக்களுடைய கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. Now I request our dynamic president, Dr. Ramesh Babu, to deliver president's address.
Thank you, Dr. Rajendran. Good evening, all. Respected seniors and respected professors, respected past president Dr. Ismail, president-elect Dr. Suresh Balan, our dynamic secretary Dr. Rajendran, treasurer Gopal, and today's program is on CME on anemia in children. Dr. Janani Madam has arranged it in a unique way that all the speakers, the convener and moderator, and the resource person, all are ladies. Madam, it's a nice one, madam, giving chances to all youngsters too. And at this juncture, IAP TNSC feels proud that in conducting this monthly CME successfully every month without any interruption. And this is the 5th CME for the year. Today's topic is CME in anemia in children. The convener is Dr. Janani Madam, moderator Dr. Meena Madam, and the resource person Dr. Syed Rabia is also going to talk on interpretation of CBC indices and the peripheral smear, and a case-based discussion by 6 speakers, namely Dr. Vasanthi Thiruvengadam, Dr. Pinky Vedavanam, Dr. Venkateshwari Ramesh, Dr. Arathi Srinivasan, Dr. Lakshmi Madam, Dr. Divya Nandakumar. At this juncture, I place one request to all the participants, as well as the delegates, as well as the seniors and the professors, though this is apart from the academic activity. I request all of you to motivate pediatricians who are not members of IAP to enroll them into the IAP fold and make them as life members. And the seniors, professors, faculties, please motivate your postgraduates and DNB students to become associate life members so that we can improve our membership strength of IAP Tamil Nadu State Chapter. With this one request, I wish this CME to be a grand success. Thank you for the opportunity. Over to Dr. Rajendran to carry out the proceedings further.
Thank you, Dr. Ramesh. Respected our president, Dr. Ramesh Babu, and treasurer Dr. Gopal Subramaniam, and our AAA, Dr. Thirumurugan Sarani, and all state and as well as central IAP members. And today's program convener, Dr. Janani Shankar, and moderator, Dr. Meena Shankaran, and resource person, Dr. Syed Rabia, and all other faculties, and seniors, Dr. P.S. Shankar Narayanan, Dr. Srinivasan sir, and all other respectable members. On behalf of IAP TNSA, welcome one and all. This one of the wonderful CME on anemia in children, and as Dr. Ramesh said, all our women, they are organizing it, and really we are happy that we are doing a wonderful work past almost 2 or 3 years post COVID era also we are continuing. And once again, I welcome one and all. And now I request our program convener, Dr. Janani Shankar, please take over.
Thank you, sir. So we thank you for giving us this opportunity. And when you told us to do a CME, initially I thought I'll do it on fever, but then there are too many CMEs on fever, and I thought anemia is one clinical condition which is little neglected, and most of the important conditions that cause anemia or misdiagnosed or undiagnosed, or delayed diagnosis is made in most of these children. So we thought it will be most useful to the postgraduates, clinicians, and senior people to go through the lab parameters that are useful in diagnosing anemia. And we thought we'll have case-based discussion by panelists, and all of them, I'm proud to say that all are consultants from Kanchi Kamakoti Child's Trust Hospital. The entire team is from KKCTH, and it's an all-women team, as you mentioned. So I'm sure it's going to be a real feast to all your ears. And without much delay, I introduce the resource person, the moderator, and the panelists for this CME. The resource person is Dr. I request all of you to switch on your videos, please. Meena, all the panelists, please switch on your videos. Vasanti, Divya. Yeah. So the resource person is Dr. Syed Rabia. She's a consultant hematologist, pathologist, and blood bank medical officer, the key person who's responsible for making our life easy. She's the one who, really makes things easier for the clinicians by calling us and telling us whatever we expected. So she's going to talk on utility of lab parameters, the basic labs which are usually neglected, like your indices, complete blood count, and peripheral smear in diagnosing different types of anemia. Then we have Dr. Meena Shivashankaran. She's a consultant hematologist. She's done her fellowship in hematology from Apollo Children's Hospital, and she's our hematologist, and she also heads the she's also in charge of the bone marrow transplant team along with Dr. Deena Dayalan. So Meena will be the moderator for the panel on different case-based discussion on anemia. So the panelists are Dr. Vasanti Thiruvengadam, again our senior consultant pediatrician and my own batchmate from KKCTH. Then we have Dr. Lakshmi, she's the emergency consultant from Kanchi Kamakoti Child's Trust Hospital. We have Aarti, again our oncologist from KKCTH. We have Venkateshwari, senior consultant KKCTH. Pinky, consultant KKCTH, and Divya, registrar KKCTH. So they'll all be discussing different cases, and which will be moderated by Meena. So in the end, we'll finish with some concluding remarks and take home points. So without much delay, I hand over the mic to Syed Rabia. So please share your screen and start, Rabia. Others, please keep yourself muted. Share your screen, Rabia.
Yes, ma'am. Good evening to all the panelists.
Visible and audible, carry on. Yeah.
Yes, ma'am. Can you hear me, ma'am?
Yeah, we can hear you.
Okay, okay.
Yes.
Good evening to one and all. Good evening to all the panelists and all of you attending. Thank you so much, ma'am, for that introduction. Thank you all for welcoming me on this Sunday to this prestigious fold of pediatricians. Today, I'm going to talk about one of the tests that are done, which is statistically the most frequent test in our hematology laboratory, which is the CBCs and also peripheral smears in anemia. CBCs are often ordered here, but they're a more precious resource elsewhere. And this seminar is going to be a bit about how you can hack the most out of your CBCs and get the most information that you can from what is a relatively cheap test. So even before we feed it into the machine, these are our EDTA containers that come in. We get about 2 ml of potassium EDTA anticoagulated whole blood. And as you can see, even when they are left to sit out like this, you can see that some have separated and dropped a lot more, whereas others are a little more, almost half, 40%. So these are normal, and I know that this sample is going to be anemic. And what other information I get from this, from just samples that have been let to sit out, is that whether there's lipidemia, whether it's lipemic, whether there's icterus, whether there's been some form of intravascular hemolysis. So really our job starts from receiving the sample into the laboratory. And again, this is how my morning reporting tray, one of the many trays, look like. And I know that the first one or the first second is probably a critical alert kind of anemia, just from judging from the color of the slide itself. Whereas this is a newborn, and you can see that it is a lot darker, as we assume physiologically the hemoglobin to be a lot more. So you would have seen all of these devices last, hopefully, in your pathology MBBS practicals. You have the Newbar chamber, counting the total WBC count in 4 squares, RBCs in 5 squares. You have the Sallies, and you have Westergren and Wintrobe, and you're hoping that you don't swallow a mixture of Turk's diluting fluid and blood. And all of this has been made very easy, and it's been shifted to a hardly a 2-foot or a 3-foot tall machine, a tabletop machine. As you can see, these are auto analyzers. So all medium, small laboratories, all of it have auto analyzers now. We have simple analyzers.
I am attending the CME. Right. You also attend the CME now.
So we have 3-part analyzers which give only granulocytes, lymphocytes, and monocytes. And you have higher end models that are in high volume centers, and these give you anything from nucleated RBCs, they give you reticulocyte count, they give you 8-part counters, they make the slide. There is literally, and they take photographs of 100 cells. There's literally nothing that these higher end machines cannot do, but the fallacies of those will also be discussed. So ideally, we need around 2 ml of blood, but in newborns, we are okay with 500 microliters, 0.5 ml of blood, and EDTA is what we generally use for our CBCs. In some circumstances, we ask you especially for a citrated sample. This is when we suspect that there are anti-EDTA antibodies, as can be seen in scrub typhus, platelet satellitism. But again, clinically, it is important to correlate. Just because there are platelet aggregates does not mean there is a scrub antibody roaming around. It could also mean that it was not mixed well. So talking to the clinicians, asking about fever, asking about an eSCAR, all of this is important. So just a single slide on how the machine works. When we feed this blood into the machine, a small amount gets aspirated. And through a principle called hydrodynamic focusing, every particle in the blood is counted. So each particle goes one at a time, and it causes a change in the pulse. It causes a resistance. There's 2 electrodes, and each of the change in the resistance is pulsed like this. And then we have a Gaussian curve being formed. From this, we get the mean corpuscular volume and also the red cell distribution width. It's interesting to note that both RBCs and platelets are counted in the same chamber. So same principle. So anything that's between 2 and 20 femtoliters is counted as a platelet. Anything more than 36 femtoliters is counted as an RBC. And this is where all our confusion comes in case of giant platelets versus schistocytes, and peripheral smear comes in useful then. WBCs are also counted by the same principle. This is the Gaussian curve that you derive. This is, I would say, normal in a pediatric patient. You have mostly between 70 and 80, whereas in microcytic, there's a nice shift to the left. Most of the pulses, most of the MCV is less than 80. And here there's a nice shift to the right. There are a lot of RBCs that are more than 110 in corpuscular volume, as well as this one is when we have a trouble. The machine will register around 85. But what we have is a broad base, almost dual peak. You have both microcytes as well as macrocytes, but the machine may not show much. It might come only as an Normocytic anemia, and RDW comes into play then. This is the scatter plot for doing a differential count. Lymphocytes get captured here. You have neutrophils here, eosinophils here, and monocytes getting captured here. And then you have gray zones. Somewhere between here, your dengue lymphocytes get captured. Here, blasts get captured. Your NRBCs get captured. So it's interesting to come down and look at the scatter plot once in a while to see why the DC changes after they've done a manual check. This is done by a principle called volume, conductivity, and scatter. Depending on how complex your WBC is, eosinophils are a lot bigger, lot voluminous, lot more complex. So it gets collected here, counted there. This is a sample of what comes to us. I'm just going to put 2 of these. As you can make out, some get flagged by the machine itself. It gives you a lot of information. The hemoglobin is low in this case. This is the shift that we spoke about. The MCVs come as 55. And the platelet is a little on the higher side. And otherwise, it looks normal. The WBCs look normal. And this is an iron deficiency anemia. You have the MCV being low. RBC should be low. It's okay. It's not high. The hemoglobin is low and the platelet is a little on the higher side. This, just looking at this, we have a normocytic anemia. RBCs are on the lower side. Okay. Hemoglobin is low. MCV appears to be normal. Platelets are low, but there's a lot of noise happening here. The machine has flagged a total count of 46,000, and there are lots of cells going right here. And this turned out to be an acute lymphoblastic leukemia. So this is the last one. This was in a patient with dengue. Again, your RBCs are on the higher side. Your platelets are low. There's lymphocytosis. What's interesting to note is that your RBC is not low. This is because of the hemoconcentration that you can see in dengue. So it has to all be interpreted with clinical history as well as peripheral smear examination. There is no one-size-fits-all approach to anemia. As a clinician, I assume that you would approach anemia depending on when it sets in, newborn versus infant and toddler versus an adolescent female, or the etiological cause of anemia. For us, it is more like a morphological approach. Is it with the three indices that are most important and that strike out on the CBC, the mean corpuscular volume, the mean corpuscular hemoglobin, and the MCHC in one condition is very important, or the dynamics of anemia. Is it anemia of destruction or due to low proliferation, where the reticulocyte count and the reticulocyte production index is important. Reti count is again a very cheap test. For any case where the hemoglobin is less than 8 grams, we go ahead with the reti count. It is a time-consuming test, but actual money and reagent wise, it really does not cost that much. So it is important to do a reti count, especially if the child gets transfused, and then we are in a bit of a conundrum about this. And the reti count, we use a supravital stain or a brilliant cressyl blue or new methylene blue. So microcytic, we say anything less than 80 femtoliters. But in pediatric, what we do is start from 70 and add 1 for every year that the child becomes. So 71 for a 1-year-old and so on. And we use a combination of both the morphology as well as the kinetics of anemia. So the most common is, of course, iron deficiency anemia and lead poisoning, which is a form of Citroblastic anemia where lead gets deposited in the marrow and there is not availability of iron is made reduced. And we have thalassemia trait, Cydoblastic anemias, which are not really microcytic. They are more dimorphic, I would say, and copper deficiency. If the retic is high, more than, let's say, 2.5%, but in acute hemolysis, it is much more. Thalassemia syndromes, hemoglobin CME disorders, and pyrocyclocytosis. Pyrocyclocytosis is a membranopathy due to deficiency or abnormality of spectrin, as a result of which you have very small RBCs, and those get picked up as microcytes. It's not truly the RBC which is small, it is the affected membrane disorder RBCs which are small, and they eventually evolve into hereditary elliptocytosis. And normocytic anemia is anything between 80 and 100 femtoliters. Depending on the reticulocyte count, we classify it as low and high. And anemia of chronic diseases due to infections or autoimmunity, SLE, etc. In case of a transient red cell aplasia, not like a bone marrow failure, a transient red cell aplasia, you have normocytic anemia. In malignancies and renal failure, we have normocytic anemia. But in each of these, you may have stigmata on the peripheral smear, as well as your clinical history and other biochemical labs that will help you. Anything that is episodically a hemolytic anemia, for example, an immune hemolysis or an enzymopathy like G6PD, your microangiopathic hemolytic anemias, they all present with normocytic anemia, but we have to remember that microangiopathic hemolytic anemia, if the schistocyte count is more than, say, 15% of your RBCs, it might get captured by the machine as microcytic anemia. Macrocytic, again, lower inadequate retic count. You have mostly your B12 and your bone marrow failure syndromes, your endocrine disorders, metabolic disorders, and in liver disease. And what I've found is that in true megaloblastic anemia, the MCV is very much higher than you would see in, for example, a hypothyroidism or a liver disease. You have an MCV of more than 110 femtoliters being recorded, but this is not set in stone rule. And macrocytic with a high retic count will be hemolysis, because all of these polychromatophils or young RBCs, your reticulocytes, are much larger in size than your routine RBCs, mature RBCs. So they all get captured as macrocytes, as well as congenital dyserythropoietic anemias. So now you found out that it is an microcytic anemia. The MCV is truly low. These are the other things that can help you, most of which you get from one single CBC itself. For example, in IDA, the first thing that you see is an increased red cell distribution width. The RBCs tend to be on the lower side. The Menza index is more than 13. Peripheral smear, yes, it shows microcytes, hypochromic cells. Hypochromia actually sets in before microcytosis itself. You have elliptocytes, pencil-shaped RBCs, and so on. History is also very important. When you call and ask for history, they say it's an IDA right away. There is that is how much they have worked up to even before the CBC comes out. And iron studies wise, ferritin is most useful. It is usually very low in these cases. In anemia of chronic disease, the RDW is not really very contributory. It tends to be normal. RBCs are on the lower side. Menza is not contributory. Peripheral smear also nothing. It's just a diagnosis of exclusion unless it's a renal disease where you see burst cells. And history wise, there will be a very strong history of some chronic illness and so on. And ferritin tends to be high in chronic diseases. In TAL trait, the RDW again, in trait, it does not tend to fluctuate high much. RBCs, however, are on the higher side, and Menza is useful here. Again, history is important. Make sure there is no cause for hemoconcentration, for example, dehydration or dengue and so on. In Citroblastic anemia, we tend to see peripheral smear findings, which I'll be showing now. This is IDA. We use a small lymphocyte for comparison. The nucleus of the small lymphocyte is bigger than the adjacent cells. So, and also the pallor is more than 1/3 of the cell. And this was actually an adult patient. This was a 30-year-old male. He presented with anemia. It looked like a clear iron deficiency anemia, but the clinician himself called and told me, no, there is some alternative medicine being given. The stool occult is not normal. Can you please check? I've sent a tox screen also, and it did turn out he had a high level of lead, and this was useful. We saw these coarse basophilic stippling on the peripheral smear. In Citroblastic anemia, you can see one really strong set of RBCs and one pale small RBC. So it's a dimorphic anemia. And you see Pappenheimer bodies in the peripheral smear, whereas this is a bone marrow. We've done a special stain called Pearl's Prussian blue stain, and you see sideroblasts. So this was an interesting case, because only hemoglobin was asked for it earlier. And when a CBC came, it was interesting to note that the RBC count was on the higher side and was not really a very worrisome hemoglobin. The platelets were okay, the WBC was okay, the machines told you there are microcytes and there's hypochromia. And this is where the Menza comes into play. And since we do a PS for every case, whether it's a CBC or hemoglobin, we take a peripheral smear. And our technician goes through it, and there were target cells on this case, and it turned out to be a thalassemia, beta thalassemia trait. Here you can see cells with a central, there is some hemoglobin in the center. These are podocytes or target cells. You also have some teardrop cells. This, however, is how a florid thal major would look like. You have multiple, apart from the microcytic hypochromic anemia and lots of polychromatophils, you also have NRBCs. This is the pyrocyclocytosis we were talking about earlier. By adulthood, it tends to evolve into elliptocytosis, but all of these small cells, almost fragmented cells, tends to get picked up as microcytes. Speaking of normocytes, really, I told you there was not much that the peripheral smear can tell you, except there is some rouleau, especially in case of tuberculosis or autoimmune diseases. In case of uremia, you can make out these cells called Burr cells, but these can also be seen in an old sample or in case of acidosis and so on. And this is again a normocytic anemia. This, as you can see, is an irreversibly sickled cell. You also have Howell's body suggesting that this child is probably older and there is some asplenia and polychromatosis as well. This is what I told you about microangiopathic hemolytic anemia sometimes getting picked up as a microcytic anemia, because you can see these schistocytes. All of these get picked up as microcytes. You can also see an NRBC, and NRBC in an older child is very worrisome because it is indicative of some destruction and proliferation happening. This was a newborn in which was a male child. We picked up these blister cells as well as cells that look like a bite has been taken out of them. And this is where the reticulocyte, our supravital stain, comes in useful. You can make out what was a blister here, what did not get picked up here is actually picked up here as a Heinz body. Now these cells look very dense, very small, but are they microcytes? No, because there's no pallor, they're completely dense. And this is because the MCV is picked up as normal, but they look small on the peripheral smear because you have to see that this is a two-dimensional picture. So it's like a cricket ball, a dense spherical ball that gets flattened between your cover slip and your slide. And these are microspherocytes or spherocytes. We commonly see this in hereditary spherocytosis as well as in autoimmune hemolytic anemias. There's also a Howell-Jolly body suggesting that there is some rapid hemolysis that's been happening. So we do osmotic fragility tests in this. We can say that because they are hard, dense balls, they don't take much water. There's also a problem with the membrane lipid bilayer, as a result of which it starts lysing much earlier and there's a shift to the right. Conversely, in case of thalassemia trait, in case of iron deficiency anemias, the test is shifted to the left because they can take a lot more water. And one thing is that these OFTs require heparinized blood. And if the patient has already been transfused, what can be useful is doing a CBC for the patient. These are all tricks I picked up from our clinicians. This is actually shows up as a normocytic anemia, but it is not truly normocytic. There is a dimorphic peak, a combined nutritional anemia, or an iron deficiency anemia that has started responding to treatment, and so you have retics that are getting picked here. Moving on to macrocytes. So this is an interesting case. This is a Monday morning kind of case. So what happens is that we get a call in the night from the hematology, from blood bank. Blood bank people tell me there is no correlation between forward grouping and backward grouping. Everything is coming positive and the autocontrol is positive, and the hematology technician tells me CBC is hardly 1 million, hemoglobin is very low, and MCV is 135. In the morning when we take the sample out, they tell me "Three irukku, madam," and it's a very watery because of hemolysis, as you can see, and this is because of this phenomenon where you have cold agglutinins, IgM mediated, and all of these big agglutinated cells get picked up as one RBC. The RBC count is also low, as well as the MCV being disproportionately high. This is test line, as you can see. You have completely hemoglobinized, oval-sized macrocytes, teardrop cells, you have Howell-Jolly bodies, and hypersegmented neutrophils. Just even one of these, because it has multiple segments, like you can see 1, 2, 3, 4, 5, 6, 7 lobes, single cell, scopes in a single cell, that is sufficient for us.
Rabia, can you check your audio? There is some disturbance in your audio.
Yes, ma'am. Can you hear me now, ma'am?
Yeah, better. Yeah.
So this is another cause of macrocytic anemia. Multiple clues, as you can see here. There are burr cells. There are some cells that look like burr cells, but not quite. They are not as regular as you see. They are irregular bulbous projections, and you have target cells, and you also have platelets being low. You should see a lot more. This is a platelet. You should see a lot more on the slide, but it is low, and this turned out to be liver. As you can see, how we do the reticulocyte count is we count 1000 RBCs and we do a percentage of how many of these are young RBCs. That is what is reticulocyte count. And more important in hemolytic anemias is the reticulocyte production index. So the corrected reticulocyte count, we have to correct it down for the patient's hematocrit divided by the normal hematocrit for that age and gender. And that gives a more realistic, is less scary than your count that is recorded. And what you see here is what you can see in alpha thalassemias and HPH disease. These are called golf body inclusions. This is where another cheap test comes really useful. And we already saw Heinz bodies. Is it only an anemia? Can we just look at this side of the CBC and leave this part of the Coulter? No, it is important to look at all the other lineages as well. They provide a lot of useful clues. For example, if there's pancytopenia, there is either something in the marrow, for example, a malignancy or an infiltrative process, a granulomatous process. The history sometimes will elucidate what has happened. The child must have been on a myelosuppressive drug, infections, especially viral infections, HIV, CMV, or in case of hemophagocytosis, post-viral infections. In case of an aplastic anemia, where the MCV tends to be a lot more, or the bone marrow is fine and something is just getting destroyed in the spleen, And ultimately, the most important cause of pancytopenia, or the most common cause that we see in pediatrics, which is a vitamin B12 and folate deficiency. I just said pancytopenia, but as you can see, the screen is chock full of these abnormal cells. That is because what presents only as a pancytopenia, nothing scary on the peripheral smear as such, turns out to look like this on the marrow. They tell me that the marrow the technician tells me no particles on the marrow, but it is jam-packed with these cells. These are all lymphoblasts. As you can see, they have very scant cytoplasm, very open chromatin, and inconspicuous nucleoli. And this is aplastic anemia. This is a histopathology or a trifine section. This is more useful. You can see bone here. These are all bony. This is the 10x power view. You can see bone, and all of the marrow has been replaced by these adipocytes or mature fat cells. Hardly 10% of the marrow is retained, if any. Now, the next algorithm, anemia with low platelets. We already discussed the microangiopathic hemolytic anemias. There'll be a clear history, or the clinician will even tell you, I'm suspecting an atypical HUS in this case. And yes, we will pick up schistocytes and NRBCs. And another rare but important syndrome is Even syndrome. There, as you can see, there's a warm autoimmune hemolytic anemia. And we also see an immune thrombocytopenia in these patients. And what is useful in immune thrombocytopenia is the presence of giant platelets in the peripheral smear, or the mean platelet volume. It might be even though the count is low, the MPV may be 12, 13 or more. And anemia with high platelets, you have a reactive thrombocytosis in case of iron deficiency anemia. And post-plenectomy, you can have thrombocytosis, as well as you might still see stigmata. For example, you might still see Howell-Jolly bodies, spherocytes, even post-plenectomy. Anemia with leukocytosis. The other aspect of leukemia, we saw one leukemia where there was pancytopenia, and there is the other process where it has started coming out into the peripheral blood. You have a leukocytosis and a bicytopenia or other bacterial infections, and spurious in thalassemia. I'll show you why. So this was a child, it was a 6-month-old child. It's beyond the machine's capacity to even count the WBCs. It's 1,42,000, and it has asked us to dilute because the machine can only count up to 1,20,000. The model that we were using then could only count to 1.2 lakhs. We had to dilute and do, and everything was given by the machine: leukocytosis, large immature cells, atypical cells, blasts, and it was quite worrisome. And as you can see, even the platelet histogram is not good. There are a lot of non-platelets that are getting trapped here, and it says MCV of 68, but no, there are a lot of these cells between 36 and 80 that have not really been captured. And this actually turned out to be a case of thalassemia major. These were all NRBCs that have been picked up. NRBCs have been picked up as WBCs, but the newer machines now give even a corrected WBC count. They give you the number of nucleated RBCs, but this is one of the cases where the peripheral smear is seen right away. It's a critical alert. And this is a more bacterial type of infection where you have, or sepsis, where you have all these toxic appearing neutrophils. They're all mature neutrophils, but they're very toxic, and some bands coming in. And an important thing called leucarthroblastic blood picture. You can see an NRBC, you can see anemia, you can see a metamyelocyte, a myelocyte, as well as mature cells. This is more indicative of something replacing the marrow, for example, a storage disease, or it could be an osteopetrosis or MPN bar MDS, like a JMML. So this again is something scary. It is physiological in cases of newborn, or if there's a respiratory distress syndrome or something like that. But otherwise, this warrants more investigation. So it is mostly a collaborative effort. The machine might seem very advanced, but it has its own fallacies. Similarly, without clinical history, you see the peripheral smear once without the history, but never release it without. So you don't get the bias, but to never release the PS without getting the history, because one thing can mean one in another condition. And I think that wraps it up. Thank you so much for this opportunity. Thank you, ma'am. Thank you to all.
Thank you. Thank you, Rabia. That was a wonderful presentation from your side. I think you brought the importance of history for a lab person. Yeah, that's very, very important. We always tell the students to write a brief note about the history so that you also know what you have to look at. So that the teamwork should continue. Thank you. I request all the delegates and the participants to type out the questions in the chat box. We have time to discuss, a lot of time to discuss the chat box questions. So moving on to the, so thanks Rabia again.
Thank you so much, ma'am. Thank you.
Yeah. So a lot of feedback from the audience. You can look at the chat box. So now moving on to the panel discussion. It will be a case-based discussion on, and different types of anemia will be discussed by all the different faculty. The moderator will be Dr. Meena, and at the end of each case, there'll be take-home points given by Meena and a brief summary about that type of anemia. Over to Meena.
Is my screen visible?
Yes, visible, Meena. You're audible and visible.
Okay. Good evening, one and all. I thank the IAP Tamil Nadu State Chapter for giving this opportunity to talk about anemia in children. I thank Dr. Rabia for the wonderful presentations on how to interpret the Coulter and how to interpret the peripheral smear findings in our day-to-day practice. This made my job easier for further discussion. In the next 1 hour, we will have a case-based discussions about different causes of anemia. Slides are not moving.
Inside the slide, Meena.
Once it
If you click inside the slide, it will move. Again, share, stop and again share. Request the panelists to keep your video on, please. Vasanti, Pinky. Now you try moving. Yes. Okay.
Anemia is defined as hemoglobin, hematocrit, or the RBC cell mass is less than 2 standard deviation below the mean for age. And the pathophysiological definition is when the oxygen carrying capacity of the blood is reduced. These are textbook definition for the clinical use for the based on the WHO. For the children less than 5 years, if the hemoglobin is less than 11 gram per deciliter. For adolescents, if the hemoglobin is less than 12 gram per deciliter. And based on the level of hemoglobin, it's divided into mild, moderate, and severe. If hemoglobin is less than 7 gram per deciliter, it's considered as severe anemia. There are 3 main causes of anemia. One is due to the red cell destructions, acute or chronic hemolysis, such as autoimmune hemolysis, or thalassemias, membranopathies, enzymopathies, or due to inadequate production, could be due to the marrow failure syndrome, or marrow is replaced by leukemias. And other causes is the blood loss. And now Rabia told about the modern cell counter, which will give us a hemoglobin, hematocrit, RBC count, and MCV, RDW within a minute. And based on this MCV, if it's between 80 to 100, that considers normocytic. If it's less than that, it's microcytic anemia. If more than that, it's macrocyte. If they have a dual population of the cells, that will consider the dimorphic. This will help us in clinical diagnosis of the anemia and for further classification. Let's move on to our case-based discussion. This first case will be discussed by Dr. Divya. We have a 10-year-old girl who presented with easy fatigability. On examination, she had severe pallor and her anthropometric measurements were normal. There was no bleeding manifestation, no significant lymphadenopathy, and there was no organomegaly. This was a clinical finding. When we removed her hijab to look for the lymphadenopathy, we looked into. And Dr. Divya, what is the most striking feature in this girl? What are the clinical pointed towards anemia?
Good evening, everyone, and thanks for the opportunity given. So, a 10-year-old adolescent girl presenting with pallor and on examination having severe anemia. And there is no focus in the history, like her diet is normal, there is no obvious bleeding patterns, and there has been no fever or weight loss. And on examination, we find that her growth pattern is normal, and there is no significant adenopathy or organomegaly. But on a closer look, we find that she has severe lice infestations, and we can also note that there are nits and even lice moving all around her head. So we should be meticulous in carrying out a full examination of the child. And what are the pointers towards anemia? So it depends upon the age at presentation and the severity of anemia. If the anemia is only mild, compensatory mechanisms come into play and they present only with mild irritability. However, if it is severe, they can present with high output cardiac failure. And in case of young children and infants, the most common presentation would be irritability and behavioral changes, and there will also be history of pica. In older children and adolescents, they will have history of easy fatigability, exercise intolerance, and palpitations. So we should take a detailed history to look for causes of anemia also.
So here is a 10-year-old girl with severe pallor and has an infestation. So we suspect iron deficiency anemia based on the history and clinical examination. So we proceeded with supportive investigations, complete blood count, and peripheral smear. Do we interpret the complete blood count and peripheral smear finding of this girl?
So when we look at the complete blood count, we first have a look at the hemoglobin. So as we see, the hemoglobin is low for her age, and concomitantly we see at the other cell lines. We see that the total count and the platelet counts are normal. So, and then if we look at the indices, we see that the MCV is low and MCH is low. So it's microcytic and hypochromic, and the RDW is also raised. So while having a look at the CBC count, we should also make it a point to look at the RBC count. As we see here, the red blood cell count is also decreased, which will give us a clue to differentiate iron deficiency anemia from thaltrate. So when we look at the peripheral smear, as was earlier discussed by Rabia ma'am, we can see that the size of the RBCs are reduced when compared with the size of the nucleus of the small lymphocyte. And we also see the central pallor is increased. So the peripheral smear finding is suggestive of microcytic hypochromic anemia, and we can also see anisopoikilocytosis.
And this is the RBC histogram, which shows the shift to the left. That means suggestive of the low MCV. This child has pallor and has the infestations with low MCV, MCH, and MCHC, and with raised RDW. RBC count is proportionately reduced, and this clinical pictures and the laboratory findings, it goes towards the iron deficiency anemia. How would you manage this child?
So this child has no features of any cardiorespiratory failure at presentation. So it's a stable child. So we have to start this child on oral supplements of iron. And the most common iron salt we use is a ferrous sulfate. So this should be 3 to 6 mg per kg of oral iron started. And it should be given for a duration of 3 months to replenish the iron stores. And we should also make it a point to tell them that the iron should not be taken along with food or milk so that the absorption is good. And it is also meticulous to treat the cause. As in this child, we have to treat the parasitic infestation. The lice infestation was so severe that it would not subside only with anti-lice medications. The child had to undergo even tonsuring. So we should also stress on the need for proper diet and iron-rich supplements.
When would you consider packed red blood cell transfusion in a child with iron deficiency anemia?
Only when the hemoglobin is very low, like the HP is less than 4 grams per deciliter, or if there are any signs of cardiorespiratory decompensation or failure when the hemoglobin is between 4 to 6 grams per deciliter. And in cases of anemia with failure, we'll prefer giving small and frequent transfusions like 5 ml per kg packed red blood cell transfusion, along with IV diuretics in between.
With this child, we have started on the iron supplements. We have tonsured and treated the underlying cause for the iron deficiency anemia. And what is the expected response to the treatment, and how do you follow up this child?
So the first response we expect in this child will be an improvement in subjective improvement. So since there will be replacement of iron enzymes, the irritability will be decreased and the child will have signs of increased appetite. And the reticulocyte count will improve at 48 to 72 hours, and the hemoglobin will start improving by day 4 and will increase by 1 gram per deciliter at the end of 1 month. At the end of 1 to 3 months, there will be replenishment of iron stores.
What are the possible causes if this child is not responding to our oral iron supplements adequately? What are the possible causes for the inadequate response?
Once we have started on iron supplements, when the child comes for follow-up, we should see the improvement in the overall clinical status and the pallor of the child. Before ruling out other diagnoses and ruling out other problems, we have to make sure that the child is taking the medications compliantly. So what is the compliance of iron medications? So we can ask them like how many bottles of iron they have used, what is the color of the stool on taking iron supplementation. And if the compliance is good, we have to make sure that the dose and the duration of therapy is correct. And we also have to rule out ongoing blood losses if any is present. And if the child is taking the iron medications properly, we should see if there are any, if the child is taking it along with any oral antacids or H2 receptor antagonists. As we all know, iron is being absorbed in the proximal duodenum along with gastric acid. So any interference with iron absorption like oral antacids or PPIs can also present with not a very good improvement in hemoglobin. And if there are any problems in absorption like malabsorption or diarrhea, we will not expect a good improvement in hemoglobin. And finally, after ruling out all the other causes, we should make sure that the diagnosis is correct. If there are other conditions like thaltrate or any other associated deficiencies like folate or vitamin B12, we should identify them and correct it. Then only we can find an improvement in hemoglobin.
Thank you, Divya. As Divya said, if the child is not responding to the oral iron therapy, we need to look for the compliance, look for the ongoing blood loss, and look for the alternative diagnosis. When would you consider iron studies in this child, and what are the indications for the iron studies in a child with iron deficiency anemia?
So in our child, the main cause for iron deficiency anemia is lice infestation. So we have treated the cause and we have started our own iron supplements. So we follow up the child at 2 weeks to 2 weeks later and at 4 weeks. If there is no proper improvement in hemoglobin, there is no improvement in subjective improvement, and we see that she is not responding to oral iron, so we will then go ahead and do next set of studies like iron studies. And if we have any other differential diagnosis like thalassemia trait or Citroblastic anemia, we will go ahead and do next set of investigations like serum ferritin, which is the most sensitive indicator of the iron stores, which will be decreased in iron deficiency anemia. Others would be like serum iron, which will also be reduced. Total iron binding capacity will be increased, and percentage saturation of transferrin, which will be decreased in cases of iron deficiency anemia.
It's, as we have said, it's routinely iron studies is not required in iron deficiency anemia. If they are not responding to the therapy, if their compliance and drug dosage is good, and if other GI causes are ruled out, look for the iron studies and to rule out the other secondary causes. There is an entity called iron refractory iron deficiency anemia. This occurs due to the mutations in the TMP RSS gene mutations. This results in the defect in the iron absorption. Children with these conditions will need long-term high-dose oral iron therapy along with ascorbic acid supplementation. If they are not responding to high-dose oral iron, need to keep them on the parenteral iron supplement. So if iron deficiency anemia child, if they are not responding to oral iron therapy, look for the compliance, look for the drug dosage, look for the GI causes, either GI malabsorption or do the stool occult blood to look for the underlying chronic blood loss. If these causes are ruled out and iron indices are suggestive of like low ferritin, low iron, and increase in the TABC, if iron indices suggestive of iron deficiency anemia, think about this entity called iron refractory iron deficiency anemia. What other causes, coming to the other causes of the microcytic hypochromic anemia, apart from iron deficiency, anemia of Rabi has already discussed about other causes. It's anemia of chronic disease and thalassemia and Citroblastic anemia. Here, Marrow will clinch the diagnosis. As Rabia had earlier shown, its ring sideroblasts will be there in the marrow. And if the child is not responding to the oral iron therapy, don't keep on loading them with iron. In Citroblastic anemia, keep on giving iron supplementations will actually worsen the clinical condition of the child. If they are not responding to the iron therapy, look for what is the underlying cause, why the child is not responding to the therapies. And other causes, lead toxicity. So in iron deficiency anemia, they will have the microcytic hypochromic, low MCV, and with low RBC count and high RDW. And here comes the Menser index, it's MCV by RBC count, that is more than 13 in iron deficiency anemia. In case of thalassemia trait, they'll have low MCV, high RBC count, and RDW is normal. MCV by RBC count is Menser index, that is less than 13 in case of thalassemia trait. So consider iron deficiency anemia as the most common cause of microcytic hypochromic anemia in children. Diagnosis is mainly based on the clinical history and examination. Complete blood count and smear will support our diagnosis. If child is not responding to the therapy and the compliance is good and drug dosage is good, and look for do the iron, perform the iron study, and also look for the GA causes to look for the other differential diagnosis, and oral iron therapy and dietary modifications and treatment of underlying cause are the usual recommended therapy. Now we will move on to the next case. This will be discussed by the Dr. Vasanthi ma'am. Here is a 6-month-old infant brought for the evaluation of the developmental delay. The child is on exclusive breastfeed and mother is a vegetarian diet. On examination, child has pallor, well-nourished, and has hypopigmented hair and hyperpigmented knuckle. Ma'am, what are the salient features in this child? And what are the pointers, clinical pointers for the further diagnosis?
Thank you very much for the opportunity, and I have a very good evening. Given to us an infant, 6-month-old with the developmental delay, pallor, and hyperpigmented hair with hyperpigmented knuckles. And the very important thing to note in this condition is the mother being a vegan, and a vegan diet, which can cause a B12 deficiency, which could also attribute to the deficiency in the infant. The child also has pallor, but it's very important to note the child is well nourished otherwise. And the child, in addition, has hyperpigmented hair and hyperpigmented knuckles, which is probably suggestive of a B12 deficiency. So discussing the clinical features of B12 deficiency, and before we go into the, before we have any clarity about megaloblastic anemia, a macrocytic, and it's very important to have a clarity on macrocytic anemia. Macrocytic anemia, secondary to B12 and folate deficiency, leads to megaloblastic anemia. All other macrocytic anemias are probably non-megaloblastic. So going on to discuss the clinical features. There's folate deficiency. This child, this may be because of the yellow complexion of the child, maybe because of a mild jaundice due to ineffective erythropoiesis and mild hemolysis. And glossitis is probably again due to B12 deficiency. Hyperpigmented knuckles and nail beds are due to the decreased levels of reduced glutathione, which is required for the activation of tyrosine kinase, which may help in the transfer of melanosomes, which is usually affected in this condition, hence the hyperpigmented knuckles and nail beds. Neurological manifestations are very peculiar to B12 deficiency and not so much in folic acid deficiency. And they include infantile tremor syndrome, developmental delay, loss of milestones, or loss of developmental milestones, or a developmental delay, and hypertonia. In older children, usually the children can present with loss of position sense, vibration sense, and ataxia secondary to B12 deficiency. This is probably because of the lack of methylation of the neuronal base protein and lipid, leading to demyelination. That is the proposed theory. And finally, thrombosis in megaloblastic anemia. So I think this gives clarity on the type of deficiency we are dealing with. And with respect to investigations, more often we can have a pancytopenia or a bicytopenia and a low hemoglobin, a reticulocytopenia. And as you can see, the WBC is only 2000s, and which is indicative of leukocytopenia, and hemoglobin is as low as 6 grams per cent. MCV is 115 femtoliter, and this happens mainly in megaloblastic anemia, where the MCV is usually more than 110. And high RDW, as high as 29%, is indicative of increased anisopoikilocytosis, probably because of ineffective erythropoiesis, and thrombocytopenia. All this are indicative of existing megaloblastic anemia. In the peripheral smear, what are the things in the peripheral smear in a child with megaloblastic anemia? So, the triad of a macroovulocyte, usually in megaloblastic anemia, you can have macroovulocytes, whereas in other forms of macrocytic anemia, you usually have macrocytes, which are usually the most.
Vasanti, you check your audio, Vasanti, it's not very clear.
Audio?
You're breaking in between, yeah.
Can you hear me?
Yeah, it's
now?
breaking. You're breaking in between.
Is it okay?
Yeah, it's okay, but in between there are breaks. Just check, yeah.
Okay. Macroovulocytes, and in megaloblastic anemia, however, in other forms of macrocytic anemia, you will have macrocytes which are rounded. Then the presence of hypersegmented neutrophils. Hypersegmented neutrophils are usually indicate or very strongly suggest the possibility of a megaloblastic anemia. Here you will have more than 5% of 5-lobe neutrophils and 1 or more of 6-lobe neutrophils, which are highly sensitive of the diagnosis of megaloblastic anemia. And the presence of Cabot's ring, or and the presence of Howell-Jolly bodies. Howell-Jolly bodies are indicative of the presence of nuclear remnants. And Cabot rings, can you hear me?
Yeah.
It's
Now, Janni, is it clear?
Yes. You can switch off your video. Switch off your video. Vasanti, switch off your video, then you'll be more clear. Yeah.
and the presence of the Cabot string, which is remnants of the mitotic spindle and basophilic stippling, all are suggestive of an ineffective erythropoiesis of megaloblastic anemia. So, and a bone marrow, which is hypercellular with megaloblastic erythropoiesis. All this would suggest a possibility of a megaloblastic anemia. So, to summarize the diagnostic features of megaloblastic anemia, you have pallor, developmental delay, hyperpigmentation, reduced hemoglobin, and red cell indices indicative of a high MCV, and RDW is also increased. Red cell distribution bit is also increased, and leukopenia, thrombocytopenia, and the peripheral smear suggestive of macrovillocytes and hypersegmented neutrophils. So we can, in this child, we conclude that probably the diagnosis is a megaloblastic anemia.
Yeah.
So going on, yes.
Yes, as ma'am rightly said, it's based on the pallor and neurological manifestations, hyperpigmentations, and CBC and peripheral smear finding. We are suspecting towards it. This child clearly has a megaloblastic anemia. In megaloblastic anemia, bone marrow is not indicated usually. In case of if clinical features not able to differentiate from the other aplastic anemias or malignancy, in that case we will do the bone marrow. It's not generally indicated. They will have the hypercellular marrow with megaloblastic picture in megaloblastic anemia. And how will you confirm the diagnosis further with our biochemical investigations?
Given the clinical picture and the peripheral smear features of megaloblastic anemia, we would go ahead and do a B12, serum B12 and folic acid levels. If the B12 levels are less than 200 picograms per ml, it's suggestive of a cobalamin deficiency. However, if the folate levels are less than 3 micrograms per liter, suggestive of a folate deficiency. This sometimes it may be indeterminate, whereas the B12 levels and the folate levels may not be very suggestive of a deficiency. They may be just about the normal values, or even just about even slightly higher than normal. So in these conditions, when you have a strong suspicion of a B12 deficiency, or a folic acid deficiency, go ahead and do a plasma homocysteine levels and a plasma methyl malanoic acid levels. The B12 and the folic acid actually act as cofactors in the pathway of homocysteine from the conversion of homocysteine to methionine. Hence, any disturbance in the pathway would lead to increased homocysteine levels. And that is why in folate deficiency, you have only homocysteine levels elevated and you have a normal MMA. However, in B12 deficiency, the conversion of methyl malanoic acid to succinyl-CoA also takes place with the help of a B12. So in B12 deficiency, whenever there is impairment of conversion of methyl malanoic acid to succinyl-CoA. Hence, the MMA levels are also high. So to identify the presence of B12 deficiency, you have increased levels of homocysteine and methyl malanoic acid levels, whereas in folic acid deficiency, it is only homocysteine and normal methyl malanoic acid levels. And the most important surrogate marker in megaloblastic anemia is the elevated LDH. You can see the figure is as high as 2,560 in this child, so it is very much indicative of increased cell turnover. And hence the high LDH. And there's a mild hemolysis indicative of a Billy of 2.7 and the retic. In spite of such severe pancytopenia, the retic count is just about 4%. And the B12 levels here indicative of is 71, which is very low. So in this child, probably we can conclude that there is B12 deficiency.
We have an infant with megaloblastic anemia. What is the underlying cause for this child, and when would you investigate for causes other than the nutritional?
Okay. There's multiple factors which can contribute to the B12 deficiency and folate deficiency. And one is the most important thing is which we see in infancy, wherein if the mother is totally vegetarian, or that can attribute to B12 deficiency in early infancy. And folate deficiency, mental deficiency of folic acid, prolonged breastfeeding, ingestion of cow's milk, prematurity, all of which can contribute to folate deficiency as well. However, if there is a prolonged deficiency, this can happen in defective absorption. or defective transport, metabolic disorders, all this can lead to prolonged deficiency in B12 and folate, which can manifest even in late childhood and into adulthood. So these children and early childhood, they can present with those are when B12 deficiency or due to congenital intrinsic factor deficiency, pernicious anemia, and Emerson-Dasbach syndrome, wherein you have tubulin deficiency. That is a mutation of the tubulin receptor defect, which helps the transport of B12 across the ileum into the bloodstream. So when this is defective, you can have B12 deficiency. In addition, Emerson-Dasbach they can also have in proteinuria and vitamin D malabsorption as well due to the tubulin defect. Then malabsorption in B12 deficiency may be due to other intestinal pathology. In folate deficiency, the malabsorptive pattern may be right from the neonatal age, maybe due to congenital reasons, or could be due to acquired post-intestinal surgery. And you should always remember that it could be because of any drugs, like antifolate drugs like methotrexate and other antibiotics, AEDs. All this can also interfere with the conversion of dihydrofolate to tetrahydrofolate due to in competitive inhibition of dihydrofolate reductase deficiency. And a defective transport happens in B12 deficiency due to transcobalamin deficiency. This is required for the transport of cobalamin in the intestine as well as in the transport of cobalamin in the blood. And folate deficiency due to folate gene mutation. Then metabolic disorders. These are disorders wherein you have to substitute B12 and folic acid for a lifetime because these are not going to be corrected and they have to be continued for lifelong, such as methylcobalamin, adenosylcobalamin deficiencies, and congenital methylene tetrahydrofolate reductase deficiency as far as folic acid is concerned. And you should also not forget about orotic aciduria, which is common to both, where B12 and folate is required for the ornithine cycle to happen. So any defect in the cycle can lead to orotic aciduria and hence can present with both B12 and folate deficiency as well.
Thank you, ma'am. Now we have an infant with megaloblastic anemia secondary to the nutritional cause. And how would you manage this infant? And how often you come across megaloblastic anemias with developmental delay? How do they respond to the therapy?
The treatment is usually of the underlying cause. You need to treat the underlying cause. If there's any deficiency, it has to be corrected. And a dietary supplementation of B12 or folic acid supplementation might also help. And it should also, it's also important to note that folate stores can last as long as 4 months, and hence deficiency symptoms develop very rapidly. Whereas B12 stores last for as long as 4 years. So symptoms and signs start very slowly and can take a longer time for the B12 stores to get replenished. In folic acid deficiency, if the infant is less than 6 months, you may have to substitute 50 micrograms of folic acid in a day. Whereas if the infant is older than 7 months to 13 years and in older children and adults, the substitution dose will be 1 to 5 milligrams per day for as long as 3 to 4 weeks, followed by 0.1 micrograms to 0.5 micrograms per day till the levels normalize. In vitamin B12 deficiency, it is very important to remember that you can have malabsorption or metabolic disorders, which will need substitution of B12 for a supplement B12 for a lifetime. And it is also important to note that oral medications may not help, and you need to give parenteral B12. Parenteral B12 in the range of 500,000 micrograms per day, daily for 2 weeks, followed by weekly replacement till the hematocrit normalizes. And you may have to continue for a lifetime. You may have to substitute it weekly for 6 months, and then monthly for a lifelong period for replenishing the vitamin B12 stores. However, if you have to substitute it orally, you can give it for as long as 2 weeks, oral B12 for as long as 4 to 6 weeks, then weekly till the hematocrit normalizes in mild deficiency states. So, and you should always remember that when you give B12 and when there is concomitant folic acid deficiency, folic acid should not be started initially. B12 supplement should be started almost a week. After a week, maybe you can start folic acid because once you start on folic acid, it can worsen the neurological manifestations of B12 deficiency. And during the process of treatment, you should always remember that iron deficiency and hypokalemia may also occur during the treatment and hence should be managed appropriately.
Wanted to add few points. If a child has severe thrombocytopenia, consider intravenous supplementations rather than intramuscular supplementations. And what is the expected response in this child with regard to the neurological symptoms and then well-being and improvement in the HB?
Well-being usually starts within 48 hours, and the reticulocytosis usually starts by about 3 to 4 days, peaks for almost in a week's time, and then resolves in about 20 days. And there's also an increase in hemoglobin, total count, platelet count, all of which will increase in about 10 days time, and which usually normalizes in 6 to 8 weeks. That is very important. And once you see the normalization of these values, then probably you can come down to maintenance therapy. And bone marrow recovery usually starts within 6 hours to 72 hours. However, neurological impairment, in the present neurological symptoms, it may take a little longer. And sometimes this dementia and personality changes can get better in a period of weeks. However, the paresthesia and other neurological symptoms may take weeks to months and sometimes may not even improve at all. So, and hence the replacement of B12 therapy should be lifelong for neurological impairment. And thank you, Meena. I hand over to Meena for further discussion on megaloblastic anemia.
Thank you, ma'am. There are other causes of the macrocytic anemia. Apart from, ma'am had a detailed discussion about the megaloblastic anemia. Apart from the nutritional deficiency, there are other conditions called time-in-responsive megaloblastic anemia, hereditary orotic aciduria, metabolic disorders, Imerslund-Grasbach syndromes, and other GA causes ma'am has discussed in detail. And apart from the megaloblastic marrow, there are non-megaloblastic causes of macrocytic anemias, marrow failure syndromes such as acquired aplastic anemias, Diamond-Blackfan, Fanconi, and marrow infiltrations due to leukemias, lymphoma, neuroblastoma, and congenital dyserythropoietic anemias. And apart from this, we can have systemic disorders like liver diseases and hypothyroidism can present with non-megaloblastic macrocytic anemia. In these liver disorders and hypothyroidism may have isolated anemia without being other cell lines are normal. And liver diseases, because of hypersplenism, they can have concomitant pancytopenia. Marrow failure, aplastic anemia, Fanconi's anemia, they can present with other cell lines pancytopenia, but they don't have the features of megaloblast, that is like hypersegmented neutrophils and megaloblastic pictures in the marrow. And Diamond-Blackfan anemia, they present with isolated macrocytic anemia with other cell lines are being normal. Marrow infiltrations due to leukemias, lymphoma can present with isolated anemia or with pancytopenias. And B12 and folate deficiency are leading cause of megaloblastic anemia. Look for the clinical pointer. This child had a background exclusively breastfed from the had a vegetarian diet and had developmental delay, hyperpigmented knuckles. These gave clues towards a megaloblastic anemia. And child also had, and look at the complete blood count and peripheral smear findings, had pancytopenia with the megaloblastic picture, macroovelocytes with increase in the RDW and had the hypersegmented neutrophils and other peripheral smear findings of the nuclear maturation defects such as basophilic stippling, Cabot ring, Howell-Jolly bodies. These are the findings we need to look for the CBC and peripheral smear. Based on the history and CBC and peripheral smear, we can diagnose the megaloblastic anemia. Always either isolated iron deficiency or megaloblastic anemia is not a diagnosis per se. We need to look for the underlying cause, such as like whether it's only due to dietary inadequate or due to the GA causes or any other underlying inherited or other possible differential. So investigate for the underlying cause. And if serum B12 and folate levels are indeterminate, do the methylmalonic acid level and homocysteine to confirm a diagnosis. Along with replacement, treat the underlying cause. Whenever we are replacing, always consider first replenish the B12, then after a week initiate the folate supplementations, because if you are concurrently starting both B12 and folate, that will worsen the neurological manifestation. And during the treatment, they can develop the iron deficiency. So after a week of B12 folate therapy, start the iron supplementations along with and look for the underlying cause. If the child is present with recurrent megaloblastic anemia, and look for the urine proteins, there is a presence of the urine proteinuria that is suggests towards the Imerslund-Grasbach syndrome. They won't respond to the oral therapy. They need long-term parenteral therapy. And thiamine responsive megaloblastic anemia responds well to the thiamine supplementation. So look for the associated sensory neural hearing loss and diabetes mellitus. And we'll move on to the next case. This will be discussed by Dr. Venki ma'am. We have a 5-year-old girl noticed to have pallor for 2 months duration and have skin bleed for 1 month and gum bleeds for a 1 month duration. On examination, there was no dysmorphic feature. Her anthropometric measurements were within normal limits and has pallor and has oral bleeds and skin bleeds and no significant lymphadenopathy and organomegaly. Dr. Venki ma'am, as a pediatrician, what are the red flag signs from the history and physical examination of this child?
Thanks, Meena. Here we have a 5-year-old girl. Looks like she was a previously well child who's come with symptoms of some 2 months duration. The moment I see the history, I know that this is not a simple iron deficiency anemia because along with pallor, this child has also come with some bleeds. The child has both skin bleeds and mucosal bleeds. So I know that there is not only one cell line which is affected there, that there is more than one cell line involvement in this child. So I would also go back and find out if this child has involvement of WBCs too. So I would like to get a history of recurrent fever or history of infections in this child. So the moment I see that there are 2 cell line involvement as per the history, I know that I need to get a detailed history for any child who presents with Pancytopenia. So as a general pediatrician, I'll be very happy. I know that most of the post-viral bone marrow depressions can come with some mild Pancytopenia. So I would definitely get a history of recent viral infections, something to suggest viral infections. And as pediatricians, we always look forward to treating something which is very simple, underlying reversible causes. So the previous session, we had a very detailed discussion on how Pancytopenia, the most easily treatable and reversible cause is B12. So I would definitely go back and get a dietary history in this child. I would actually specifically look for hyperpigmentation along with pallor in this child to rule out megaloblastic anemia. For any general pediatrician, when a child comes with a complete blood count showing pallor as well as thrombocytopenia, I'm always worried about malignancy. So I'm worried that I should not miss a malignancy in a child who has more than one cell line involvement. So I would definitely go and get back again, ask the mother about fever, about bone pain. And in my general examination, I would actually specifically look for any significant lymphadenopathy, any significant organomegaly in that child. And as pediatricians, when the parents say that the child has been previously normal, we all know most of the handful of children can have inherited problems, can come with inherited problems, and they can walk at any time. They don't have to necessarily come to us at birth. So even though this child was previously well child, I would still like to think of inherited causes of Pancytopenia. So I would go back and again do a detailed examination. My anthropometry will give me a very good clinical clue if the child has short stature. And a head-to-foot examination shows that this child has dysmorphism. This child has some neurocutaneous markers like multiple capsular spots. This child has some limb anomalies, some skeletal anomalies. Then I know has some thumb anomalies. Then I know that this could be an inherited bone marrow failure syndrome. So a simple Pancytopenia, we need to go back and get a very detailed history in all these children. And if it is an older child, I know a child with connective tissue disease can come with a primary hematological manifestation. I can have a child with lupus who's 10-year-old, who's come with just pallor and bleed, but then this child could be having recurrent fever, oral ulcers, joint symptoms, skin rash. So just because they come with a hematological manifestation, we should not just think that this could be a simple iron deficiency anemia. We should always go back and look for red flag signs. And very rarely you can have children with storage disorders, children with extrahepatic portal venous obstruction, who have a huge spleen, who can come with hypersplenism, and come with Pancytopenia. So in any child who comes with more than one cell line depression, I would start from ruling out a simple cause to a very treatable, reversible cause. And I would actually go up to thinking of very rare causes like my inherited bone marrow failure syndromes too. And I would always be very careful not to miss a malignancy in any child who comes with more than one cell line involvement. So this child has got 2 cell line involvements as per history. And on my clinical examination, this child's anthropometry is normal, does not have any dysmorphic features. So in any child who comes with pancytopenia, it all depends on the underlying bone marrow pathology, whether it is a hypocellular marrow or a normocellular marrow or a hypercellular marrow. So in this child, I would just like to keep myself open. This child has 2 cell line depression. As of now, I have not found any clinical clues for malignancies. I have not found any clinical clues for inherited bone marrow failure syndrome in this child. So I would still like to look into the complete blood count as well as the peripheral smear and look for any treatable reversible causes in this child. So we'll proceed with the complete blood count in this child.
We proceeded with complete blood count, smear and bone marrow examination. This is a complete blood count of this child.
So the complete blood count shows a normal WBC count, but I know that there is a significant neutropenia in this child. So I would still, so this child comes under pancytopenia, though the WBC count is normal. The RBC count is low, the hemoglobin is low as expected, and the MCV is 98. The MCV is normal, the MCV is normocytic. We all know that bone marrow failure syndromes, though they commonly present with macrocytic anemia, they can also come with normocytic anemia. So this child has a normal MCV. This child has a normal RDW and the platelet count is low as expected. So this child has pancytopenia, and strikingly the reticulocyte count is very low. So there is reticulocytopenia. So I know that there is something wrong with the bone marrow. There is some ineffective erythropoiesis. The bone marrow is not doing its job. So I would like to go and look into the peripheral smear, still look for any findings to suggest megaloblastic anemia. As Rabia told, I'm not finding anything strikingly for megaloblastic anemia. I'm finding normal sized RBCs. I hardly see any WBC on the smear, and there are no platelets. So this child has pancytopenia. So I know that this peripheral smear does not show anything to suggest a megaloblastic anemia. So I proceed to go ahead with the bone marrow aspiration in this child. And as pediatricians, we all need to remember, whenever we have a child with pancytopenia, we should expect a difficult marrow in that particular child. So in our hospital, when we have a child with pancytopenia and we plan a bone marrow, we always take Meena's help because we know this could be a dry tap. We could have problems in doing a marrow in this particular child. So whenever we have pancytopenia, we plan a bone marrow aspiration along with a biopsy, along with a trephine biopsy, because we should not end up with a dry marrow and later it will be very difficult. We have to redo the procedure again. So whenever you evaluate a child with pancytopenia, always plan a bone marrow aspiration along with a biopsy. So in this child, the bone marrow is very striking. I hardly see any cells. So, and I don't see any abnormal cells either on the peripheral smear nor on the bone marrow. All I see is too much of fat. So I know this is my undergraduate teaching. The bone marrow has been replaced by fat. So this child has got aplastic anemia. So, now I have an explanation. So this child who presented with 2 cell line depression and complete blood count showed pancytopenia. Peripheral smear did not show evidence of megaloblastic anemia. Peripheral smear did not show evidence of any leukemia or any infiltrative disorders. And bone marrow is actually, and there was striking reticulocytopenia. And the bone marrow is showing classic findings of aplastic anemia. So I know this child is no longer my child. This child has to go to Meena because the child with aplastic anemia has to go to the hematologist for further evaluation. In any child who comes with aplastic anemia, I know this we have to rule out common secondary causes of aplastic anemia. We know viral infections can present with aplastic anemia. We know connective tissue diseases can come with aplastic anemia. So even though we don't have any clinical clue in the history, we have to do this baseline evaluation of viral markers. We have to do a baseline autoimmune evaluation. And we know this child clinically does not have bone marrow failure syndrome finding. The anthropometry is normal. There is no dysmorphism. But still, I would do a baseline screening ultrasound abdomen and an echo on this child. And we all know rarely we see paroxysmal nocturnal hemoglobinuria presenting as pancytopenia. So we need to screen this child for paroxysmal nocturnal hemoglobinuria. And though this peripheral smear is normal, there is no hypopigmentation, and deep down I know that this is not megaloblastic anemia, I would still like to document a B12 and folic acid level in this child.
These are the values in this child. Viral markers are...
The viral markers are negative and the autoimmune evaluation is also negative, and as expected, the B12 and folate levels are normal. and screening echo and ultrasound doesn't show anything. So we classify aplastic anemia as mild, moderate, and severe aplastic anemia depending on the degree of marrow involvement, along with the severity of neutropenia and the severity of reticulocytopenia. As per the definition, this child will come under severe aplastic anemia. So in any child with aplastic anemia, though we know that this child does not have any clinical findings to suggest the inherited bone marrow failure syndrome, it is imperative, it is our duty to do a baseline screening for inherited bone marrow failure syndrome. This is a very important take-home point because many children with inherited bone marrow failure syndrome can deceive us without any clinical findings. So it is very important that we do a screening chromosomal breakage analysis on these children. And if it is suggestive of inherited bone marrow failure syndrome, we proceed with the genetic testing. It is what is the clinical implication is, once you know that there is an inherited bone marrow failure syndrome, the hematologists have to change their regimen when they plan the chemotherapy as well as when they take up the child for bone marrow transplant. So though we know that there is no clinical evidence of bone marrow failure syndrome, we have to do a screening for inherited bone marrow failure syndrome, even in any child who presents with aplastic anemia.
Thank you, ma'am. When we have a child with pancytopenia, decrease in all the cell lines, it's RBC, WBC, and platelets, look for the clinical clues. It could be from nutritional anemia and post-infection causes to malignancies, hemophagocytic lymphohistiocytosis, or storage disorders, or osteoporosis. It could be wide variety of causes. So look for the clinical, as ma'am rightly said from the beginning, look for the clinical clues of the nutritional causes, look for the clinical clues of the autoimmunity, skin rash, or joint pain, and look for the features of the leukemias or lymphoma, lymphadenopathies, organomegalies, and look for the causes of the inherited marrow failure. So look for the family history. So always in any child with pancytopenia, that history and clinical examinations will give clues towards how we need to proceed further. Based on the history and then clinical clue in any child with pancytopenia, next step is to complete blood count and peripheral smear to look for the possible causes, and to always have in a mind, as ma'am said, whenever we have the child with pancytopenia, it could be secondary to the underlying malignancies or aplastic anemia. We will expect the difficult marrow. So always along with bone marrow aspirations, we need to consider bone marrow biopsy. Based on the clinical clues and based on our complete blood pictures and peripheral smear finding and bone marrow, need to undergo the further etiological evaluation for the child with pancytopenia. Now we will move on to our next case. We have a 4-year-old boy who was bottle fed and he was noticed to have pallor. He was treated as iron deficiency anemia, but though he did not show any improvement with oral iron therapy, his hemoglobin is further dropped from 9.4 to 5.8, and he also has a history of undocumented fever on and off, and he has leg pain which was more at night and reassured as a growing pain by the pediatrician. And on examination, he had significant pallor and bilateral enlarged cervical lymph nodes and mild hepatomegaly, though there was no significant bleeding manifestations. Dr. Aarti ma'am, what are the red flag signs in the history and examination of this child?
Thanks, Meena. Now, see, what happens is more often when we look at this history, when we look at this straightforwardly, it looks like, yes, a 4-year-old boy who's been predominantly a milk-fed child, probably we think of iron deficiency anemia. Yes, we are right probably in thinking as a pediatrician, but what happens, there are some unusual things that has been happening in this child. It's not, we know that because of this, it's not like a normal child who's been coming with some pallor and we get treated and the child responded. So we are going ahead with the next step here. As in the previous case, you saw Dr. Venkateshwari had discussed a few things, unusual things in the clinical pointers. What I would, as an hemato-oncologist, first look at is this child had pallor, was treated for iron deficiency. But what is most striking here is child have been having some kind of fever on and off, which is usually not happening with a normal iron deficiency. Child with usually iron deficiency anemia should not be having all this fever, which probably you can even attribute to frequent infections, but not like we need to rule out something else because the hemoglobin has been dropping and the pyrexia, which is associated with pallor, cannot be a normal one. Then the other striking features, which I will probably bring out here, is the leg pain. Now, leg pain, what has been happening? Yes, many of these children in this age, iron deficiency anemia, people usually, parents, it's a very tendency for us to attribute it to the tiredness. The child is having low hemoglobin, not able to walk. But yes, when somebody says that child is having a leg pain, usually sometimes what happens is we see that leg pain is more in the night. That is, they often say that the child is, getting up in the night with having more pain. Usually when you see there is some kind of little bit of minor differences, subtle differences, where you can put it off as a growing pain and the other one as a bone pain due to the other things like something like malignancies. That is what we are more worried about here. So if you consider this leg pain, if you see that children usually progressively will even start refuse to walk, and that will be usually not just that kind of joint pain which usually child says after playing and then is being better off, sleeps well. It's not that. Child may not even sleep well, because of it the sleep may be disturbed. The child may even refuse to put their foot down and even refuse to walk, and may be associated with the tiredness. More often, even if the parents attribute this to the probably a coincidental injury, which because of they had fallen and has been not able to walk. But I think we should be straight when there has been so many things happening in the background, we should be able to connect. More often, it so happens that because of that tiredness and other things, because of the pain, the child is not able to walk, has a fall, and then we attribute that to the injury. But it's actually the other way. So a leg pain in a child who's been having pallor and who's not having fever, I would definitely not probably take it as a simple iron deficiency anemia. So, okay, so the next one. One second. Okay. So the next is what we are trying to look at is that is the clinical features. What we saw here is some kind of a that is the cervical nodes that has been seen along with in the child who has been having a pallor. Now, why do we think that a child who's having a pallor, having a cervical nodes is significant? Because that may suggest some other etiology rather than just having a child with a simple iron deficiency anemia. We would not consider to be having as a should not be having a cervical nodes or even an organomegaly for this matter. So with all these clinical features, my high suspicion would be on ruling out a malignancy in this child. So for which I would probably go ahead with the further investigations. So these, the red flags, what we considered was the leg pain and the fever. So yes, now what happens first, what I would go is the complete blood count. As in all the children, the blood count gives us a very good information of what has been happening with the child. Usually we are all very good friends of, pathologists. Even if the pediatrician has seen, we all go back and ask the pathologist to review the smear again to tell us if there have been any subtle clues. So what happens is, we have seen the child has got anemia. The child has got a bit of lower counts, and we see there is strikingly a lot of lymphocytosis that has been occurring. Yes, though it can occur in a mild infections, but that gives us a clue, like along with the pallor and that platelet glowing low. Yes, there has been something in a child who's been having a leg pain. Yes, we allow to? I would, in fact, with this, I would straight away say that yes, this child needs a marrow. We need to rule out a malignancy, and then we go ahead and do the other things. So here again, anemia, thrombocytopenia, low counts with a predominant lymphocytosis on the smear will give us a clue. Yes, there is something else happening in the marrow, and to look out into the marrow morphology. So we'd go ahead and do a morphology, yes, which would probably, as in the last case, we saw that there is probably a bit of difficult marrow that is being occurring. Even in these children, if the marrow is being packed with blast, it's going to be a bit of difficult marrow, because in the periphery, you may not, as Dr. Rabia had told, you may not sometimes have a very important or a very good clue in the peripheral smear saying that there are blasts or anything, but that we cannot just, with this picture, we cannot give away saying that, okay, there is nothing on the smear, we shall hold the marrow. No, this is a very important point where even if the smear is like this, we need to go ahead and do the bone marrow. Yes, and this child was suggestive of a BALL. So that is the earlier point where we have caught the child even before probably a lot of spillage before into the peripheral smear. So yes, we would again probably catch this child early and probably start the therapy. Yes, ma'am.
Thank you, ma'am. To summarize, have a high index of suspicion of malignancy if child for conditions such as leukemias, lymphoma, neuroblastomas, and Ewing sarcoma can present with severe anemia. If child is present with pyrexia of unknown origin, if they have recurrent fever with bone pain, pallor with significant lymphadenopathies, organomegaly, and in our automated CBC, alarming factors if they have pancytopenia or bicytopenia, presence of lymphocytosis towards acute lymphoblastic leukemia, presence of monocytosis towards JMML, juvenile myelomonocytic leukemias. Look at the clues in the CBC and smear. Smear, look for the immature cells, lymphocytosis, blast, and monocytosis, and other cell lines. These are the which will give clues towards the that we are dealing with possible underlying malignancies. And easy to remember is if the child has pyrexia, significant bone pain, pallor, and pancytopenia and petechiae, think about the underlying malignancies. Now, we have seen about the pancytopenia, secondary to the megaloblastic anemias, marrow failure syndromes, and leukemias. Now, we will move on to the different case scenarios. We have this case will be discussed by Dr. Pinky. We have a 7-month-old male infant born to a 3rd-degree consanguineous parents who was exclusively breastfed and has progressive pallor and lethargy of 2 months duration. And on examination, he has severe pallor, mild icterus, and has mild splenomegaly. Dr. Pinky, what are the striking features in the history and examination of this infant?
Yeah, yes, Meena. So looking into the history, mainly I would focus that this baby is born of a 3rd-degree consanguinity, and the age of onset, the baby has come to us at 7-month-old with significant anemia, severe anemia, and mild icterus. So severe anemia is ineffective erythropoiesis and some mild hemolysis happening, and splenomegaly, which is indicative of a extramedullary hematopoiesis. Looking into this history and examination, I would like to consider with the age of onset and the consanguinity as a inherited hemolytic anemia, possibly a hemoglobinopathy, and at this age and by such severe anemia as a presentation with the splenomegaly, most likely a thalassemia major. This can happen at any age. This is a kind of a classic case of presentation. If it is a minor like a thal trait, they can present late with just an anemia, or sometimes this kind of thalassemia major can present to us between 6 months to 24 months, going around requiring frequent transfusions, and then this will lead to medullary and extramedullary hematopoiesis. The child will develop a expansion of the medulla in the craniofacial bones, cortex expanding, the medulla expanding, leading to cortical thinning, and complications like osteoporosis and bone fractures, and going around with the abdominal distension with the hepatosplenomegaly and a mild icterus. So this will be the kind of presentation for a child presenting with a thalassemia major.
Yes, ma'am. Based on this child has severe pallor, mild icterus, and presence of organomegaly and consanguinity, we are thinking towards the thal in this child. And we proceeded with the complete blood count and peripheral smear to look for the further clues. This is a complete blood picture of this child.
Yeah, looking into the complete blood count, I note that the hemoglobin is very low, that is severe anemia. Next is the WBC count is elevated to 25,000, and the 3rd cell line platelet is normal. Looking at the indices, the MCV and MCH are low, so it is a microcytic hypochromic anemia. And the retic count is 2%, which is inappropriately low for such a severe degree of anemia. And looking back into the WBC count is high, but the nucleated RBC is 25 for every 100 WBC. This nucleated RBC are normally not present in the peripheral smear. They are present in the bone marrow, but because of the ineffective erythropoiesis, they spill over into the peripheral smear, and they are spuriously calculated as the WBC, leading to a spuriously elevated WBC count. So we have the picture of severe anemia, microcytic hypochromic with the inappropriately low retic count, and this LDH is elevated, showing that some degree of hemolysis is happening.
This is a peripheral smear picture of this child.
So looking into the peripheral smear, overall, the entire smear is very pale and tiny RBCs are seen. So it is a microcytic hypochromic, and the red arrowed one and the one which Meena is pointing out is a target cell. So that is a central hemoglobin with the surrounding pallor and then the hemoglobin, so which is classic of the thalassemia. Then we have the basophilic stippling. So for the low hemoglobin production, the clues are the microcytic hypochromic anemia and the target cell. For suggestion of the hemolysis, the irregular cells, the crenated RBCs are suggestive of ongoing mild hemolysis. And for ineffective erythropoiesis, the nucleated RBCs, the large RBCs with the nucleus, which are normally not present in the peripheral smear, is seen here. And the basophilic stippling, which is also a clue of the immature RBCs, and low retic count will be seen. And the indices, as already discussed, there will be low MCV and low MCHC.
Based on the history, physical examinations, and clues in the CBC and peripheral smear, microcytic hypochromic anemias with raised RDW and presence of NRBCs, we are thinking towards thalassemia. What is the diagnostic test in this child?
So the diagnostic test will be the HPLC, that is the high performance liquid chromatography. It is using the spectrometric technique, chromatogram. The hemoglobin of different proportions will be displaced, will be eluded in this test. So before going this, a little bit about the basic hemoglobin. It's a tetramer with the protein component and non-protein component. Non-protein will be the heme and the porphyrin, and the protein will be 4 globin chains, 2 alpha and 2 non-alpha, and at different ages, different non-alpha globin chains will be produced. In the fetal stage, it will be alpha 2, gamma 2, and in the adult stage, only around 6 to 7 months, the adult hemoglobin, the beta chain will be produced, and so the adult hemoglobin of alpha 2, beta 2 will be produced, and there will be a minor component of HbA2, which is alpha 2, delta 2. So in this is a normal HPLC showing that the normal HbA is 97%, that is alpha 2, beta 2. HbA2, that is alpha 2, delta 2, will be 2%, and the fetal hemoglobin of alpha 2, gamma 2 will be only 1%. So in this child, so this is the HPLC, which shows the elevated HbF. So the fetal hemoglobin is persistent because the beta thalassemia, the defect is in the gene producing the beta globins. The beta globins are not produced. So the gamma globins, which is persistent of the fetal hemoglobin, will persist. So it is showing as a peak in the HbF. Till 100% it can be shown, and the HbA2 can be 0. So this is a classic picture of a beta thalassemia major. In case of a trait, it will be the HbA2 mildly elevated and HbF also mildly elevated around 10 to 30%, and there will be decrease in hemoglobin A. So depending upon the type of the hemoglobinopathy, the HPLC will be different.
Normally, this HbF is it can be up to 90% at birth, and it reaches the normal adult value by the 1 year of age. Whenever there is a hemoglobin F, fetal hemoglobin is elevated below the normal range for the particular age, need to think about the thalassemia. If you are seeing isolated elevation, if you are seeing only with this elevation of HbF, this doesn't mean the severity. Severity, whether its child is transfusion dependent or non-transfusion dependent, it always based on the clinical feature. As in this child who's presented with before 2 years of age with severe anemia of 5 gram and that is an elevated HbF towards the transfusion dependent thalassemia. If child is presenting after 2 years of age and with mild to moderate degree of anemia and with elevated HbF, that is towards a non-transfusion dependent thal. So this child has early age of onset with significantly elevated hemoglobin. It comes towards the transfusion dependent thalassemia. Now we have, how would you manage this child?
So this child is a transfusion dependent thalassemia. So obviously first will be to transfuse the child, aiming to keep the hemoglobin between 9.5 to 10.5 grams. With regular transfusion, we should be careful with the pre-transfusion screening to avoid infections being transmitted through the blood. Number 2, due to this transfusions, the problem of hemosiderosis might happen. So we should watch out and treat with iron chelation. If not, the hemosiderin is going to deposit everywhere and lead to problems. So I would like to follow up the child for any growth retardation. Obviously, with the chronic anemia requiring transfusions, the growth will be altered with poor growth. Number 2 is because of the hemosiderin being deposited in the different organs, including the endocrine organs, I would like to check for the thyroid. They can lead to hypothyroidism, hypoparathyroidism, hypogonadotrophism, hypogonadotrophic hypogonadism, and diabetes mellitus. So I will watch out for all these complications. And important thing is that the hemosiderin will get deposited in the heart, leading to cardiac failure and cardiac arrhythmia. So to prevent all these, we have to start the child on regular iron chelators like oral or subcut. The common ones which we use are the deferoxerox, deferipron, and deferoxamine, which are the usual regular iron chelation therapy we use. And then management of hypersplenism, we watch out for hypersplenism clinically plus through labs whenever there is thrombocytopenia. Then when there is a repeated requirement of blood transfusions, also consideration of splenectomy is there, but we should also think about the post-splenectomy complications and thrombosis all. So this should be the last resort. But whenever a child with such a severe degree of thalassemia is diagnosed, first thing we have to consider is think about early hematopoietic stem cell transplant, because between 3 to 7 years, that is the ideal age during which the transplant will help and prevent transfusions and give a permanent cure for the child. And most important thing is we should also counsel the family for the antenatal diagnosis during next visit.
Thank you, ma'am. Apart from this thalassemia, other common hemoglobinopathies in our country is sickle cell anemia and hemoglobin E. Sickle cell anemia usually presents with anemia and splenomegaly and frequent pain crisis. This is usually normocytic, normochromic RBCs with elevated retic count and sickle cells in the smear. And in trade, we need to perform the sickling test to identify the sickle cell anemia. And another common entity is hemoglobin E. In this hemoglobin E, when we are doing the HB electrophoresis, HbE will come under the HbA2 window. So there will be an elevation of the HbA2. If the HbA2 or more than 20 to 30%, think about the HbE. And transfusion-dependent thalassemia, usual age of presentation is 6 to 24 months. Although the thalassemia can present at any age from the infancy to the older age group, even can present at more than 5 years, but transfusion-dependent TAN usually presents between 6 to 24 months with anemia with hepatosplenomegaly. As in this child, they'll have microcytic hypochromic anemias with NRBCs in the smear, gives clues towards the thalassemic syndromes. And in sickle cell, they'll have the normocytic normochromic anemias with sickle cells in the peripheral smear. And hemoglobin E, again, they'll present with the microcytic hypochromic anemia target cells in the smear. In these hemoglobinopathies, HPLC is a diagnostic. This will detect the variant hemoglobins. And genetic testing need to perform for the confirmation as well as to help in the antenatal diagnosis. Always need to have a high index of suspicions in the high-risk group. In a Tamil Nadu, we need to Dharmaburi, Salem, Erodu, Coimbatore belt. All need to do the screening prior to the marriage and in all the pregnant women to prevent the birth of the children with hemoglobinopathies. We'll move on to the next case and last one. We have a 1-year-old boy who presented with fever and cough of 1 week duration, and there was sudden onset of high-colored urine, pallor, facial puffiness, and he presented with respiratory distress. On examination, he was pale, icteric, tachypneic, and had organomegaly. This is the color of the urine we had. Dr. Lakshmi ma'am, what are the striking features, and based on the available information, what is the possible diagnosis in this child?
Thank you, Dr. Meena. With history of sudden onset pallor and then jaundice with preceding fever, features of congestive cardiac failure, that is facial puffiness with breathlessness, and then organomegaly and dark color red urine. So I'll think of autoimmune hemolytic anemia in this child.
What are the initial investigations will you perform in this child? And
I will do complete blood count actually to look for severity of anemia and to look for other cell lines, and peripheral smear to look for red cell fragments, reticulocyte count to look for bone marrow response, and markers of hemolysis like LDH and serum bilirubin, and DCT also I will do.
And these are the complete blood count of this child.
There is anemia and polymorphic leukocytosis. MCV is high. RDW is also high, and reticulocyte is high. The indirect bilirubin and LDH both are also very high, which suggests hemolysis in this child.
This is a peripheral smear picture, and this is the retic stain.
So this shows RBC agglutination on the top with polychromasia, and below we are seeing reticulocytes.
As ma'am said, we have seen child who present acutely with significant pallor, respiratory distress, high colored urine, severe anemia, this sort of MCV being high and has significant agglutinations in the smear. We are dealing with immune hemolytic anemia. What is the cause of high MCV in this child? Rabia had already discussed, just to reinforce why this child is having high MCV.
And this is because of RBC agglutination.
This because of this RBC agglutination, these are counted by the automated cell counter as a macrocytes. So this because of this child has high MCV and with high RDW. This child has DCT of 4+, both against IgG as well as a complement. And when we ordered the what are the types of antibodies in the blood bank, and they have told these are some cold antibody. When they warmed up the slide to the 36 degrees Celsius, the agglutination is disappeared. That indicates the presence of the cold antibodies. Now, what are the causes of this autoimmune hemolytic anemia? How would you evaluate this child further?
In general, autoimmune hemolytic anemia can be classified into warm reactive autoimmune hemolytic anemia and cold reactive. Warm reactive, it can be due to primary, that is idiopathic, or it can be secondary to lymphoproliferative disorders, SLE, immunodeficiency, etc. And cold reactive, again, it can be due to primary or idiopathic, and then secondary causes can be due to lymphoproliferative, and then infections like EBV, mycoplasma, and then paroxysmal cold hemoglobinuria. It can also be due to drug-induced hemolysis. So in this child, mycoplasma IgM is positive, and
any child with
cold reactive autoimmune hemolytic anemia.
Any child with autoimmune hemolytic anemias, look for the underlying cause of autoimmune disorders, or as well as malignancy, or whether there is any history of drug intake. And how would you proceed with the management of this child, as this child is presenting acutely with respiratory distress?
In this child with features of congestive cardiac failure and who is at the risk of developing cardiorespiratory failure, first thing I will do is I will put the child on crash cart with a 45-degree head tilt, and then I will give 100% oxygen by NRM, attach the patient with the monitor, and then I will frequently assess vitals. I will also send blood grouping and RH typing, and I will alert the blood bank about possible immune hemolysis in this child, and to arrange for best match or least incompatible unit of PRBC, which will be life-saving in this child. It may be challenging to get this unit, but we can transfuse least incompatible unit without any serious adverse effects. So I will transfuse very small aliquots of 5 ml per kg, at the same time not exceeding 2 ml per kg per hour, with a diuretic in between transfusion. And I will be starting immunosuppressants like IVIG and steroid also. And at the same time, of course, hydration is important. I will be cautious about hydration because in this child with CCF, if at all needed, I will be giving only half maintenance. And at the same time, I will be closely monitoring renal parameters, urine output, etc. in view of ongoing hemolysis and hemoglobinuria.
Thank you, ma'am. This is a paper from the Indian Journal of Child Health published by the ER team on the autoimmune hemolytic anemias. Of these, of 29 cases, 25 of them had the secondary causes such as infections, autoimmune disorders, or malignancies. And mortality was 10% in this child, and it was 90% of them did well with the best management of the ERT. And coming to summarize, warm autoimmune hemolytic anemia, the presence with features of the extravascular hemolysis, predominantly spirocytes in the peripheral smear and organomegaly. As in this case, cold autoimmune hemolytic anemia, the presence with features of intravascular hemolysis, pallor, jaundice, high-colored urine, and in smear, significant RBC agglutination. If any child with autoimmune hemolytic, as in our study, we had around 25 out of 29 had the secondary causes. Look for the underlying infections, immunodeficiency, do the HIV screen, immunoglobulin profile. If the clinical features suspicious of malignancies, perform the bone marrow examination because they will need high dose of steroids. So consider bone marrow examination in this child prior to that. And do the imaging if you're suspecting lymphomas, and do the autoimmune screen. And mainstay of management is immunosuppression along with the treatment of the underlying cause if we found is malignancies, SLEs, or immunodeficiency. To summarize, though we have the automated cell counter, which will give us clue in within the minutes of MCV, RDW, hemoglobins, hematocrit, all the parameters, always we need to go through the detailed history and clinical finding. Most of our cases, we had a clue what we are dealing with based on the clinical history and the examination finding. Carefully look at the complete blood count, not only the hemoglobin indices, MCV, MCH, MCHC, and RDW, whether it is based on the MCV, whether it is a microcytic or normocytic or macrocytic, whether it is RDW is low or high, and retic, whether it is low or high. If you are dealing with microcytic hypochromic anemia, if with the raised RDW, think of nutritional cause. If microcytic hypochromic anemia with low RDW, thalassemia, macrocytic anemia, then nutritional deficiencies, and marrow failure syndromes like Diamond-Blackfan, Fanconi's anemias, aplastic anemias, normocytic marrow even marrow failure and marrow infiltration such as leukemias, lymphomas, neuroblastomas, as well as the chronic renal diseases present with normocytic. If the presence of raised retic count, think about the immune and non-immune hemolysis. If the DCT is positive towards immune hemolysis, non-immune causes either secondary to the blood loss or non-immune hemolysis secondary to the enzymopathy, hemoglobinopathy, membranopathy. With this, I will end my session. Thank you all for the patient listening. Over to you, ma'am.
Yeah. Thank you, Meena, and all the panelists. I think it was a wonderful session. Yeah, I think last 1 hour was really, the time just went off. It was really good. Thanks to Meena and all the panelists. There are a few questions in the chat box. A few have already been answered by Rabia, myself, Vasanthi, and Venki. Meena, I think you have to answer the remaining ones.
Okay,
the question is there a test for TAL trait? I think it's hemoglobin electrophoresis.
We can do the hemoglobin electrophoresis. If it's more than 2.5%, we need to consider the presence of TAL trait. And as well as I need to mention here in the hemoglobin electrophoresis, if you're suspecting hemoglobinopathies, if you haven't taken enough adequate EDTA sample for the HB electrophoresis and you transfuse, we can always do the parental screening. If the presence of elevated microcytic hypochromic anemia with normal RBC count as well as elevated HbA2 in the parents, suggestive of we are dealing with the child with thalassemia.
Okay. So the other question is oral iron contraindicated in TAL?
If we are dealing with TAL trait, in TAL major transfusion dependent thalassemia, we should not give iron supplementation. If we are dealing with TAL trait, there will be a concomitant iron deficiency anemia. We can correct the iron deficiency.
Okay.
Even HbA2 will be initially low in child with iron deficiency anemia. We need to do the HB, if we are suspecting TAL trait, we need to correct the iron deficiency anemia, then do the HB electrophoresis to look for the elevation in the A2.
Okay. So HBE, is it always, serious or is it mild? HBE leading to,
yeah, I understood. Homozygous HBE will always present with milder form. If there is a concomitant heterozygous form like E-beta thalassemia, they can behave like transfusion dependent thalassemia or non-transfusion dependent thalassemia. Homozygous HBE will be asymptomatic apart from smear finding of microcytic hypochromic RBCs. If they have the E-beta thalassemia concomitant beta gene mutation also, they can present with either transfusion dependent TAL or non-transfusion dependent TAL.
So the other one is indirect antiglobulin test. How often do you use? Do you use it at all?
That will give us the presence of the antibodies in the patient that will not doing routinely, but that will be give us a clue towards the whether there is the presence of the antibodies in the patients. In DCT, we are mostly doing the RBC antigens. In ICT, that will detect the antibodies in the plasma.
Okay. Last question is serum haptoglobin, any additional value in addition to LDH and retic count?
That is a marker of the intravascular hemolysis.
So I think in all the cases that were discussed, I think the clinical the history and the clinical features played a vital role, and a few basic things like looking at the smear and indices helped in arriving at the diagnosis. The second line investigations was just for confirmation. Before we end, I think Dr. VSS would wanted me to share some questions for the students. Let me share that. One moment.
Meena, there is a query whether folic acid 1 milligram preparation is available.
As isolated, a 1 mg is not available.
So, I think these are some questions for the students which sir wanted me to share. History taking in a child with pallor, common causes of anemia in children, stages of WHO recommended, suggested stages of iron deficiency, spotted pica and knuckle pigmentation and finding, causes, why, mechanism, clinical significance. I think this was discussed in our second case. Severe glossitis findings, oral manifestations, including Plummer-Vinson syndrome, differential diagnosis, treatment outline, peripheral blood smear in detail, including thalassemia versus iron deficiency anemia. Peripheral smear differentiation is a famous OSCE question. Diagnosis of iron deficiency and megaloblastic anemia. I think all this was covered. Iron supplements, what, why, when, how early, how much, how long, how to monitor adverse reactions. Sir has covered all the questions in one question. Yeah, so that you should know about what are the preparations that are available, what is tolerated by the children, how much, how long, all the reactions and other. I think that was also very detailedly discussed by Divya and Meena. Megaloblastic anemia causes, clinical lab. I think that was really well discussed by Vasanthi. Hemolytic anemia case scenario. I think Lakshmi did a wonderful job. CALS, phagocytosis, lymphoma, malignancy. Again, Pinky and Aarti discussed that. Counseling of the child, parents of their child with pallor. Yeah, again, we'll go back to post-COVID. We'll go back to the regular session, or the board may go back to the regular OSCE sessions where you have counseling stations. Complications of anemia, early diagnosis and management. And one more thing was bone marrow, when will you do and what are the findings in different types of anemia. So that was the questions. Thanks, sir, for sharing those questions last minute. Let me stop sharing. How do I stop sharing? Is my screen gone or still there?
Still there.
I'm not able to stop sharing. Okay, yeah, I can stop. So, Dr. Rajendran, we have come to the end of the session. Are you there? I think, yeah. So if sir is not there, anyone else from the IAP TNSC, is there? Tirumurugan, are you there? I think they'll be expecting us to finish by 6:30, so they probably will log in again at 6:30.
Madam, yeah.
You're there?
Yeah. My driving actually. No problem.
No problem, sir. We finished before time. Thank you for the opportunity. We would like to the participants to have a nice evening with the family, so we are releasing them earlier, half an hour earlier.
Yeah, on behalf of IAP TNC, I thank Janani Madam to organize this wonderful CME and anemia. And always, whenever asking, Janani Madam always help for the teaching program, like postgraduate teaching program, as well as in CME also. I thank all the team from KKCT. They done wonderful deliberation on anemia. And I thank one and all for this opportunity. And thank you very much. Thank you.
Thank you, sir.
Thank you, madam.
Special thanks to VSS sir and Srinivasan sir for being there throughout and patiently listening to all of us. Thanks to thanks
thank you,
sir.
madam.
Thank you, Srinivasan sir. Thank you.
Thank you, VS sir, and as well as Srinivasan sir.
And Vishwanathan too. Too many questions. Like a rapid fire, you were shooting with questions. Yeah.
Thank you. I have to learn a lot.
Yeah, thank you. Thank you, Vishwanathan.
Very useful session. Thank you.
Makes us also read up and think and answer. Yeah, that's most important. Thank you all. Have a nice evening. See you all tomorrow.